Hello, my name is Cordell. I am here with Miss Jones, and I'm going to get consent to perform a thoracic and chest examination. I'm going to need consent to make this video and also make a YouTube link to give to my professor. Do you give consent?
I do.
Okay, so we begin this exam by looking at the chest. So we're going to visual inspect the chest, and it will be the chest cavity. Okay, I am going to ask her to relax for me, and I'm going to actually raise her shirt because she's female. Just to respect her, we want to keep her covered, but we're going to actually raise her shirt. Okay, and we are going to look and see at the rise and fall of the chest, if there's any lesions, if there's any crepitus, if there's any change in color of the skin, if there's any concerns that it's not moving symmetrically. In her case, she doesn't look like she has any distress. She is moving air well. Her AP ratio is normal, and we will now move into palpation. So when you think about palpation of the cavities, you would want to look at her cavity of her chest, and what I would tell you is that you would palpate the area lightly, and you would be able to feel in between the intercostal space, the ribs, okay, and under the breast tissue, because you want to make sure there's no air trapping, there's no fractures or any tenderness when breathing or inhalation. And do you have any pain or discomfort when I palpate?
No.
I'm going to do the same thing on the back, okay? And on the back, I'm just going to actually raise her here and ask her to just slightly turn, pivot. And with that, we would be looking at the back. So I would inspect her back, okay? And I would have looked and see at how her back is looking, the skin, the movement when she takes a breath in and out. And I would actually just palpate just for the areas, her scapula, any tenderness, and I would feel for if there was any subdural emphysema that was possible. Now I'm going to ask her just to take a breath in and out because I want to see the expansion of her rib cage and also the expansion and the movement of her cavity. Could you take a breath in and out? Okay, thank you. So when you look at that, now I will start with auscultation, and because I'm actually on her posterior, I'm going to start posterior, then move anterior. I will be auscultating the air fields, okay? And in her case, I am on the posterior, so I'm going to do the upper right lobe, the upper left lobe, the medial lobes, and the lower base lobes for right and left, okay? And I'll be listening with the diaphragm of my stethoscope. We'll avoid the scapula because it is a solid area. Breathe in and out every time I move my stethoscope. Rest regular for me. And you always want to compare both sides so that you could be able to identify in her lobes, air, she has good air movement, air good filtration, her cavity moves in and out without any restriction or tenderness, and it's moving together symmetrically. I am now going to move to her anterior lobe, and we are going to listen to her right upper, right lower, and we're going to do her left upper and left lower lobes, okay? And we'll be assessing to see if there was any abnormal breath sounds. And you just breathe for me as I move around. And I start at above the clavicle. This is the anterior lungs. And I would lift her breast tissue or ask her to lift it if you needed to. Okay. Now, one of the things, if the person has breast tissue, you can ask them to lift so it doesn't become awkward. Her breath sounds are clear, equal bilaterally on the anterior and posterior examination. I'm now going to actually start to percuss the area, and I'm going to actually listen just to see if there is dullness or consolidation. So now we're going to do the cavity area, and we want to make sure there's no tenderness, and we want to hear if there's consolidation or if it sounds equal on both sides. Okay, and I'm now going to start to percuss into the intercostal space, sis. Okay, and I'm going to do that on both sides. Okay, and I'm going to go and do this on the back as well. And I'm avoiding the scapula. And you want to see on this side where the diaphragm ends. So where you hear from tympani to dullness, you see the changes in the from where the expansion is. What I'm going to do is I'm going to actually do an examination when she takes a big breath in to see exactly where the dullness is or when the diaphragm expands. Okay, so could you take a deep breath for me and hold it? Okay, and I'm just going to do a quick palpation. Okay, so now we have thing and release. Okay, so now it's here. So on her examination, slightly palpate, we have about a 4 centimeter apart when she exhale and inhale where the diaphragm move is when it expands in and out. What I'm going to do is I'm actually going to feel the vibration when she actually speaks or she says a word in between the cavity. So I want you to say 99 for me.
99.
Say 99.
99.
Say 99.
99.
Say 99.
99.
And I'm going to do it at the anterior as well.
99. 99. 99. 99.
And you feel this either in the ribcage or with the palm of your hand, where you feel when she's speaking the vibration that comes off of her cavity. Okay, I'm going to ask you to do a test of a bronchoscopy, and that is actually going to be checking for consolidation. So for consolidation, I just want you to say 99 or 1, 2, 3 for me while I listen over your anterior and posterior fields. Okay?
Okay.
You could start, my dear.
99. 99. 99. 99.
Okay. And I'm going to do the same here.
99. 99. 99. 99. 99. 99.
And you will check for consolidation if you can actually hear clearly. In her case, you can't really hear. You hear the muffling, and I could see her mouth moving under the mask, but I can't really tell what she's saying. And that was a test to make sure that there was no consolidation. And this actually concludes our thoracic examination. Thank you.